I have a question for both of you. For a non-surgical patient, an athlete, say it's a senior year, it could be college, high school football player, and they have an anterior instability, but this is their last season, or they're trying to get recruited, or their last season of college, and they never play football again. I'd like to know, this is not, we didn't talk about this before. I'm just always curious about that. They decide not going to do surgery. You have maybe 3-4 games left in their life to playing football. May never play in the NFL, most likely, or may not play college. What are your parameters? You send them to therapy, but what are your parameters? At what level would you let them go back? Is it depending on the position, or because sometimes they may not get full mobility, they may not get full strength, but that's their last 1 or 2 games they're ever going to play. Have you ever had that position happen to you with an athlete, or how would you deal with that?
Dr. McGarry, go ahead, and then I'll chime in a little bit.
Sure. That's actually a common occurrence there, Brett. It really is. And that's why I think I mentioned earlier, the decision as far as what you're going to treat has to do with part of the season, because you see that all the time. And I empathize with that. I played sports too, and it's a situation like, listen, this is my last 3 games. I see that a lot, with ACL injuries too. People say, listen, can you do something to patch me through? Well, basically for shoulder injuries, it's something I feel a little bit safer in as far as getting back in there. Obviously, everybody's seen those braces you get kids in. The problem with those braces is they restrict you from doing sports or things that people need. That's why they work. And so that's why athletes hate them so much. But I'll tell athletes, and this is another time where you sit down with the athlete, but you also got to sit down with the family and say, listen, let's be realistic here. Your child's not going to be able, not going to play in the NFL. I understand 100% it's important. And if we can get your child back safely to get him back in there, there's not going to be no risk. But if we get back in there safely, then I think that's part of our job. That's what we're here for, is try to help athletes get back to play as soon as they can. So I think if a child comes back in, an athlete comes back in, they've got functional range of motion, they've got protective range of motion. If they'd be willing to wear a brace, then I have no problems at all saying, fine, let's get you through the rest of the season. If you have another dislocation, it's not the end of the world. There's still some things we can do. But it's not something that's cut and dry. It's not something one answer fits everybody. You got to sit down with the athlete. You got to sit down with their parents. You got to sit down with the coaches. Make sure that everybody's on the same page of music. But I agree 100%. If there's something we can do, sort of, conservatively to get kids back, let them do what they want to do, well, by golly, that's what we're supposed to do. So I have no problem with that whatsoever.
But I would agree with that, Dr. McGarry. I think it's somewhat position dependent. I mean, a quarterback's going to be a little tougher, than somebody who's blocking and tackling. We, just like you said, they hate the Sully braces. We put them in a brace because that's the right thing to do if they'll wear it. And I think the biggest thing, just like you said, is discussion with the family, and be prepared. It may come out again. It may not come out again, but it may come out again, and you don't want to be caught having the family say, well, you didn't tell me that he or she could redislocate their shoulder. So I think that's 100% correct. A lot of the decision, in my experience, is the athletes. Some athletes come in, they came out, they had it put back in an ER. They want no part of that. They'll join the band or something. But some athletes, you can't stop it. You tell them whatever you want to tell them. I had a kid dislocated his shoulder, play for East St. Louis, and actually is in the NFL right now, dislocated his shoulder. I told the coach and I told the parent, single parent family, he shouldn't play based on his career going to college, etc. And told everyone to, forget it, and the coach to forget it, and played and redislocated his shoulder, and now he's in the NFL. We reconstructed him, and now he's in the NFL. So again, some of the kids are going to self-select, and they're either going to play or they're going to not play. But you can give them, your best advice, and I think Dr. McGarry's advice was excellent. So Brett, since you asked a really good question, I'm going to ask you a really good question. Why don't you tell me what happened? You played at a high level. You played 4 years of college football at a top school. Tell me about your shoulder.
Well, that was leading into my question. Since high school, and I never realized it, but people would tease me. I'd always, with my shoulder, I'd always kind of do like a little habit. I'd move my arm back, not realizing what it was. And I'd always have little shoulder aches and pains. And I played, worked out a lot, worked out my shoulders. I was an outside linebacker, so a lot of my collisions was was almost coming from the side, and I'd move around from right or the left side. So I would take I was playing at 220, playing against 280 to 310 pound offensive linemen. So my collisions were coming from the side, usually taken on my shoulders. So I spent a lot of time, weight training, but really working on my shoulder strength, because I would have to take on a lot of weight with my shoulders. And never had a major injury, but always had discomfort, always had a little bit of motion in my shoulder, always had like a clicking in my shoulder. It's my left one. And not until after, and I was training and working out, and I tore my pec bench pressing, and really bad doing a bench press. And I was like, what is that? Felt like there was warm water going down my arm, and did 1 or 2 more reps back when I was strong a long time ago. Then I just started getting purple and black down my arm, all the way down to my elbow. I was in South Florida at the time, went to see an orthopedic doctor, a friend of mine, and took an x-ray. And my x-ray looked like, well, you can see like a fist, but the thumb was like that. It looked like a spur. And I had like a 7-8 millimeter spur that was coming out from my humerus. And then slowly since then, I lost full range of motion in my shoulder. Couldn't lift my arm up past the horizontal plane. And a doctor at that time said it was a major surgery. I'd be out 6 months. I'd have to get bone from my hip to replace something. So it was a whole thing that I couldn't deal with at the time. I couldn't miss work, and I just wasn't going to do it. So I really took like a 1.5 years off of lifting weights. And not until I moved to Tennessee and met with some of the doctors that I work with here, and they told me about this procedure called a resurfacing. And if you told me, just to change a light bulb, you give me $1 million, there's no way I couldn't do it. I could not lift my arm up past the shoulder plane. And all I want to do is have function in my arm. And they told me about the procedure, and you all know, but I'll say for the podcast, basically what it is they cut the head of the humerus off, and they put a cap on my shoulder. My rotator cuff was fine. My glenoid was fine. So I didn't need a full shoulder replacement. I just needed the humerus, like a mushroom cap. But in that process, they realized that my labrum was gone and my bicep tendon was gone, shredded. So I have no labrum. So the procedure that I had, which maybe about 15 years ago, was called a resurfacing procedure. You all could probably talk about it better than I can. But rehab-wise, I did the rehab myself, kind of used it as a guinea pig. I even had patients stretch me, get back to me in the clinic, so they could do range of motion on me. But basically what I learned from that rehab is my posture was so important. And almost the way I could describe it with patients now is like, if your car's tires are not aligned and you keep putting new tires on, the same problem's going to come back. So I was really good on all my exercises, really working on my posture and my scapular stability, keep my shoulder blades locked in together. I called it the 90-degree rule. So if I would bench press 90 degrees down to the horizontal plane, even military presses, I avoided certain motions like incline bench press and certain things that I just can't do anymore because of the pain, because of the metal of the humerus hitting on the glenoid. So a lot of scapular stabilizations, proximal to distal, a lot of closed chain, but really working the scapular stabilizers to keep my shoulder blade intact and keep my scapula rotated a proper way. So when I was lifting my arm overhead, I wasn't compensating using my upper traps and using other muscles I was done for like years because of my shoulder hurting. So I have full range of motion. I could do things functionally. I can go to the gym now again, not nearly as strong as I ever was, but I've gotten over that. But it's the greatest thing that to me, when and I missed 1 week of work, was in a sling for probably 6 weeks. Thank goodness it was my left arm, so I was able to go to physical therapy. I had an assistant that worked with me, so I was able to do things with my right arm, but not my left. And I have full function with my arm. I highly recommend that type of procedure, which was for me, and I thought I was going to be out for 6 months and on disability, was a miracle to me because now I have full use of my arm. So that's from years of playing football, and basically my labrum was torn probably in high school. Never wanted to get it looked at because I just kept all my other muscles, my scapula stabilized as strong so I can keep playing. Because I realized when you're playing, you don't want to miss any games. And I was able to do it at a pretty high level. until I got older. So that's my story.
Did you have your pec repaired?
No, I still no. It was more of a deviation. It's pretty bad, but it didn't affect me functionally. So that's why I went in to see the doctor to see X-ray just to look at it, see if there was something I needed to get that done. I still have an indentation in my chest from that pec tear, but the thing that he noticed was the spur, and he told me then, he goes, "You're going to need a shoulder replacement." I said, "You're crazy. I was bench pressing 315 pounds. What are you talking about?" And little did I know, I slowly started losing motion. I could not lift my arm up to on top of my head within 4 or 5 months after I injured my pec. And it was just a matter of removing the spur.
Awesome. So let's kind of move on just a little bit. And Dr. McGarry, let's talk about recurrent instability for a minute. We talked a little bit about first-time dislocators. Let's talk about recurrent instability. And can you explain to our podcast listeners on-track versus off-track instability and how that determines maybe what surgery you're going to do and how you approach that type of instability?
Yeah, that's a good question. It's a tough problem. There's actually two ways to kind of look at that. Basically, there's recurrent instability in those athletes that have not had previous surgery. And then there's those people that have recurrent instability after surgery. That second group is a very difficult group to take care of because obviously you're talking about then revision surgery. There's nothing worse than having put an athlete through a big operation, get him through the rehab, get him back to playing, and then get re-injured again, then you're back to square one. So that is, as any kind of operation, anytime you got to redo, that's a difficult operation. And talking about sort of on-track, off-track injuries, basically the whole premise of that basically has to do with the articular surface and articulation between the humeral head and the glenoid. Has to do, again, with what we talked about before as far as like Hill-Sachs lesions, that obviously if there's a bony injury that basically causes an off-track injury, where what happens is the plane of articulation between the humeral head and the glenoid gets smaller due to the pathological injury done to the bone. That obviously has implications as far as what you're going to do with those athletes that have recurrent instability but haven't had previous surgery. Those are the kind of athletes with significant bony injuries that you're going to think about more doing some kind of more involved bony procedure, like a Latarjet procedure, which goes basically inside to address more of the sort of bony abnormalities. So it's not necessarily just isolated to a soft tissue injury, but it has to do with a specific bony injury too. That being said, Latarjet operation is also sort of in my armamentarium something I look to as far as taking care of for recurrent instability in those kids that have already had previous arthroscopic stabilization surgeries. So that's something that you can consider doing too for those kind of kids that come back again, have already had surgery and then suffer recurrent instability after that. But that being said, that's a very difficult problem to take care of.
No, that was a very good explanation. So Charles, somebody comes in, they've had shoulder reconstruction, they go back to the doctor, maybe they feel it's a little loose, or maybe they're getting some tingling in their fingers, or maybe they just feel like it's shifting, so the doctor says, hey, we're going to forward you another big surgery, just like Dr. McGarry said, and put you through another 6 to 9 months of rehab. Let's try a little bit of physical therapy. How are you going to rehab that? I don't want to call it a failed reconstruction, but a reconstruction that has some post-surgical instability. Is your rehab any different? How are you going to approach that problem?
Right. So what we really try to do, we almost want to mimic the arm in a dynamic position. So that's really when we would start, instead of what I would say being close to the body, like the band work from the internal external rotation everybody's associated with. We try to get the arm kind of flexed and abducted a little bit in about a 90-degree position, and then start doing some more scapular stabilization that way. So maybe we abduct and try to externally rotate the shoulder and start doing some internal and external rotation in that position, and some dynamic stability drills with that arm, again, more away from the body, because if you're in that sport demand, that's really when you want to test that if you're return to play, is starting to be creative and not just say, hey, we're just going to do closed chain. We need to do a little bit of closed and open if we're going to really truly mimic the demands that you may see in an open field competition. So a lot of rhythmic stabilization of various sorts could be with them training in a push-up position, or get them against the wall, or them on their back and working a few different angles. So you can be as creative as you want, but once it gets to that point, it's really about trying to find a trigger that's going to really put that arm and test that position, because, again, if you're pressing someone 200 and 300 pounds, you really have to try to find the right stimulus.
So you're going to work them more in the scapular plane, or you're going to work kind of explain the scapular plane and explain kind of the principles of rehabbing the shoulder without recreating even an apprehension. You know, sometimes you get the athlete in a certain position, they don't really slip, but they apprehend, they're nervous, they break out in the sweat a little bit. So explain the scapular plane and the rehab in the scapular plane to us for just a second.
Yeah, that scapular plane, it's going to be a little more optimal for your rotator cuff as far as keeping that humeral head from slipping, if it is. So you're getting optimal and near maximal recruitment from all those muscles that help with the upward rotation of the shoulder. So you're staying in kind of more of a safe zone. So you're still in a strong safe zone where you're avoiding that apprehension and still putting them in, again, various positions. That's going to, again, get everything from the rhomboids, everything from the lower and mid trap to your primary external rotators. Again, that plane is really going to be optimal as far as trying to get any flexion above 90 degrees if they have to be in a position that's needed there. So really, your dynamic stabilization in that scapular plane is going to be optimal if you can stay there.
That's great. Thank you. So Dr. McGarry, you mentioned the Latarjet a couple of times, and maybe you could explain what that is and what the indications for a bony Latarjet are in terms of recurrent instability.
Like I said, it's a neat operation. It's very similar, like I talked about before. One of the big operations we used to do as a resident was a thing called a Bristow procedure. Basically, what the procedure entailed was going back inside and basically making a coracoid osteotomy, taking a piece of the coracoid and transplanting that to the shoulder, not only to help with the stability, but basically to also take care to accommodate the bony injury. Well, we can do that now arthroscopically. It's a big operation. It really is an involved operation. It involves significant pucker factor when you're doing that operation, but it's basically more of a bony operation that we can do now arthroscopically. That's going to do some things that help to accommodate for the significant bony injuries that if you don't take care of, obviously you're not going to address the reason that the shoulder's going to keep coming out of place because there's a bony defect. And so instead of just going in, accommodating and taking care of the soft tissue injuries, such as the labral tear or the slap injury, it's basically an operation that helps to accommodate and take care of the acute bony injury as well.
So in my experience, you're 100% right. I have a lot of trouble doing that surgery open. And we didn't have, it doesn't sound like we had the experience you had in residency. We did a few Bristows, but to me, my practice is pretty much all sports. I just cannot, I'm working in such a small hole. I find that operation immensely easier for me arthroscopically than open. I mean, the coracoid's right there. You do a coracoid osteotomy, you rotate it. It just seems a little easier. Explain sort of the complications of a Latarjet open and explain the complications arthroscopic in terms of, I guess, any of these reconstruction, axillary nerve, musculocutaneous nerve injuries. What are the complications of doing either an open Latarjet or reconstruction?
Like I said, it's a fairly involved operation. Sort of analogy I'd like to use too when I was a general surgery intern. They used to do cholecystectomy. That was sort of the kind of the simple piece that they'd throw to the orthopedic resident who was doing his general surgery internship. And we used to do those things open. I remember looking down in that hole thinking, I cannot see anything down here. Well, the advent of doing that endoscopically has basically changed it almost night and day. And the same thing, I agree with you 100% as far as changing the Latarjet now, doing it arthroscopically. But it's a big operation. Obviously you have to transplant that bone. Not only are there potential significant nerve injuries, there's potential vascular injury, And then one of the big things that potential complications as far as just getting the bone in the right position and then keeping the bone in the right position. So there are complications of having refractures. There are complications where you don't get the bone back in the right potential spot. And there are also potentials that get that bone back down in the right position and then get the internal fixation in the right spot to get it to heal. So like I said, it's a big time problem. And like I said, big time problems need to get addressed with big time operations. And Latarjet happens to be one of them. But the success for Latarjet done now well through the arthroscope is very high, a whole lot better than what we used to be able to do. So it's definitely a very valuable new procedure we have in our sort of orthopedic quiver of arrows we can use.
That's excellent, and I completely agree, and I think that's right. I mean, it's a surgery, non-union, hardware issues, etc. And there's a little bit of a learning curve to do it arthroscopically. I couldn't begin to do one open. I wouldn't even try it, but I think to get the technique down takes a little bit of experience. But I agree with you. I think it's a great operation, and I also think when you have 25-30% glenoid bone loss, you're kind of out of bullets. I mean, to do a subsequent soft tissue procedure is almost doomed to failure, especially if you're going to go back to football or hockey or lacrosse or something. So one last question I'm going to ask everybody. You got your athlete. They've had their reconstruction, and their first question is going to be always the same, and that is, when can I go back to playing sports? So I'm going to start with you, Brett, and then we're just going to go around the horn. I just want everyone's thoughts on return to play. When can you go back to swimming? When can you go back to volleyball? When can you go back to collision sports, hoops, etc. After a reconstructive shoulder procedure? And again, obviously all the surgeries are a little bit different, but in general, what are you telling that family? What are you telling that athlete? What are you telling that coach?
Well, you do it in phases. First, we got to get their range of motion normalized and pain-free. And then we'll work in the, strengthening in the therapeutic setting. And then we work on functional closed chain strengthening, and then dynamic. And then usually what I would do after that is get them to work with their trainer, or do some field, or we do some in the back of the clinic, or if we have access to the field, and do some functional training, and then progress them into pads if it's a football player, and slowly get them back. So it would just be different phases. They'd have to get through one phase to get to the next phase, and it definitely needs to be pain-free. I don't believe in getting someone back unless we talked about something where they only have 1 or 2 games the rest of their life, but we don't believe in getting them back and they're compromising their position just to get back to play, because they're going to wind up going backwards. So,
thank you. Charles, same question.
Yeah, I mean, you can give them that timeline, say, best case scenario. You can be optimistic and say, 6 to 8 months is, you're doing a lot of high functioning stuff at 6 to 8 months. If you're a thrower, that phase is a little different. You see some of these pro athletes now, these quarterbacks, they're taking nearly a year before they're back in the competition, but that's actually at the highest level when you're throwing, so you can buy yourself some time. So it gets a little dependent, like Brett said on that one. You obviously want to put them in the best position. You don't want to rush them too back. But I've seen, kids heal at an abnormal rate, it seems like, and they get well really quickly compared to some of us who are on the other side of aging. And but yeah, you just try to be upfront with the family and say, hey, here's a timeline. Here's what we think we can be. 6 months might be possible, but we're going to have better performance. We get closer to that 8 months if it's a bigger operation. And again, they're just a little variance, but that's kind of a safe timeline, and that's probably still maybe a little aggressive. I think that a lot of it depends on the athlete and how well they progress there, and that's what I found is best from a timeline perspective.
Dr. McGarry, any closing answer that question? Time frame, the athlete, mom and dad come in. How long is it going to take till Leroy gets back to playing? Number one, and number two, any closing thoughts?
Yeah, like I said, that's a tough problem. Obviously, that's the meat of the coconut. When players sitting across from me in the exam room, okay, yeah, doc, I got the injury, but when can I go back to playing? And I think it's like Brett, you mentioned too, that obviously there's not something you can chisel in stone and say, it's going to take 8 months and 1 day to get you back. Every athlete and every patient you have is different. But I tell people all the time, though, irrespective of what you want to get back to playing, there's a finite amount of time and nature and the good Lord to heal that thing. That's going to take X amount of time to get you back to playing. And I think it's specific. If you're seeing a collision athlete like a quarterback that's not only playing a collision sport, but has to do a lot of overhead throwing, I think he needs to be realistic. To try to get back to playing, it's probably going to take up a full year. I saw a study recently where they talked about in professional athletes, and they were talking about doing Tommy John surgery for elbows and shoulder reconstructions. And they said that when you're dealing with an agent, that sometimes those agents don't even, when they're negotiating contracts for you, they don't even, if you have an injury like that and a surgery like that, they say, listen, we're not even going to start to try to negotiate a contract for a full year, because it takes that long for those athletes to get back to where they're sort of based to the same level they were before. So that being said, I tell people all the time, you work hard, but realistically, the time frame to get back into overhead collision sports is, again, going to be 6 to 9 months. And if you want to get back to do overhead stuff, like swimming or tennis or javelin throwing or something like that, sometimes it's going to be a little bit quicker than that. But I just tell people all the time, I just try to tell patients, be realistic. We're going to be here with you. We're going to let you work as hard as you can. But there's a finite time that you're going to have to spend to let that thing heal back up. Makes absolutely no sense in the world to have a bad injury. You remember how painful it was on the field when it came out. There's no sense in putting you through this big operation and then try to cut corners and then have a terrible result afterwards. So we got to work together as a team. Our whole goal is to get you back out there as soon as we can. But realistic. Everybody's got to play a role. You got the most important role. But, again, like I said, it's realistic. You got to be healed up 100%, and then we'll get you back in there. So, like I said, I congratulate CORA and Dr. Lima. I think it's a great topic. It's a difficult topic because shoulder injuries in athletes, it's a difficult thing because the shoulder joint is just a complicated joint. To get back into doing functional activities like vigorous overhead activities like throwing, then you complicate things like collision sports like rugby and football. Obviously, that complicates things. But it's an interesting field because the things have changed a lot. In particular, arthroscopic surgery has really revolutionized what we can do and what we can avail of the patients have. So it's an interesting, fascinating field. It's a great field to be able to do, to be able to take care of patients, because it's something that you can realistically do some things to help these kids out that 10, 15, 20 years ago, it was just kids would come in and say, I'm sorry, you just can't play anymore. Well, that's not something we have to say anymore, so that's encouraging. And, it's just an exciting field, and it keeps continuing to evolve even today.
Everybody, you guys were all great. I just want to thank everybody and congratulate everybody. Great topic, as you said, and you guys killed it. So Dr. McGarry, Brett, Charles, you guys have a great night. And again, CORA, thanks you very much.